New York, the epicenter of the US coronavirus outbreak, and many other cities are pushing forward aggressively with antibody studies from serological testing. In New York City, 21% of the people tested had antibodies. Columbia University doctors involved in clinical trials of antibody-rich convalescent plasma told me that there are significant differences in the specificity and sensitivity of individual tests. I got a chance to join Dr. Eldad Hod on a video call where he explains the state of play right now at a clinical trial. He covers a lot of ground in his remarks. Take a listen.
Maybe I thought what I would do is first maybe give you a little overview of the uses of convalescent plasma and what we're hoping to do with it here at Columbia in New York, along with a number of other centers across the country. And so if you think about it, Diana cleared the virus and she made antibodies, and she made sufficient antibodies to clear that virus. And so we could potentially use that to help protect others with the disease. Now, this concept is not new. We didn't invent this. This has been tried for over 100 years for other viruses. It's been tried for SARS-1 in 2003, where some preliminary evidence from Hong Kong suggests that it might be beneficial. For the MERS, there just wasn't enough convalescent plasma to really do a study. And for COVID-19, there are some preliminary studies from China to suggest that this may be beneficial, but these are not controlled trials. They're just a few patients here and there that suggest that there may be benefit and hopefully no harm. And so the issue with harm we'll talk about a little later, but at the moment in the United States, the way it's working is that there are really two mechanisms for getting plasma in the blood bank. And so through the Red Cross, the Mayo Clinic, and funded through BARDA, the country is basically trying to build up a natural resource of convalescent plasma that could be used to treat anyone in any hospital for free for compassionate use. And so what that means is that if a patient is very, very ill on a respirator in the critical care unit, not doing well, and a physician wants to try using convalescent plasma in that situation, it's a pretty straightforward process, and assuming there's a supply, which is why we need people like Diana to help us generate the supply, then that patient should be able to receive it. Not that there's anything wrong with that approach, but one issue with that approach is that it will be very difficult for us to figure out whether it works or not. And at least scientifically and theoretically, there are some concerns that giving convalescent plasma in the wrong situations may actually be harmful. So it's not necessarily always going to be beneficial. So if you think about it, if someone is very sick and they have virus in their lungs and you give them an antibody that's going to target the virus, you may cause the immune system to cause more inflammation and actually make it more difficult to breathe rather than cure the patient. And so we want to proceed a little more cautiously and do clinical trials that are going to help us determine for which situations this might be useful. And so we have Diana's plasma units, it was more than one, in our blood bank, and we're saving them and hoping to begin clinical trials next week where we could try to use them in various situations in randomized controlled trials. And so what that's going to mean actually is that 50% of the patients we treat are going to get convalescent plasma, but 50% of the patients are going to get non-convalescent plasma. So they're going to get plasma from people who donated before December. And that's the only way we're going to find out whether this works or not. And I know these are ethically challenging decisions, but we need to find out whether it's going to be harmful before we can begin rolling it out to the whole population. And so we've put forward, and this is along with collaborators at multiple different institutions led by a group at Hopkins and also at Mayo. And so we've put forward at the moment 3 trials that we're going to push forward with the convalescent plasma we've been collecting at the Columbia Blood Bank. The first one is for healthcare workers. And so the evidence from prior uses of convalescent plasma suggests that if it's going to work, it's probably going to work better the earlier you give it. And so before someone is really sick. And so the people right now who are on the front lines being exposed on a daily basis, the nurses, the respiratory technicians, the phlebotomists, and the doctors, we could potentially protect them by giving them some of the convalescent plasma before they go on their shifts. And so if they test negative right now for COVID-19, And they would get randomized, and so some of them would get it, and some of them would get regular plasma, and then we would track them over time to see if there's a difference in conversion rate or a difference in whether they develop the disease or not. And the idea behind doing this as a multi-center study, as opposed to just trying to do it on our own, is that if we share the data and try to do this as quickly as possible with as many subjects as possible, we will hopefully be able to get an answer much more quickly, because if it does improve outcome, then we want to stop the study and just begin giving all healthcare workers convalescent plasma. The next indication we're going to be looking at are for those that come into the hospital, test positive, but aren't sick enough to end up in the critical care unit. They could potentially even go home where they might have other contacts. And so the idea there would be giving them convalescent plasma and seeing whether we can prevent them from coming back to the hospital or prevent them from, ending up on a respirator. And then the third indication we're hoping to start is for those sick patients who are in the ICU and they're critically ill, and we want to see whether we can make a difference in that situation. There's also some discussions about beginning a study in pediatrics, and those are still under discussion, and so we haven't begun those yet, but that's potentially upcoming. And in general, if someone gets convalescent plasma, the antibodies do circulate for quite some time, which is why we're testing them for high titer. And the issue of testing is somewhat challenging because there are currently no good tests that are FDA approved that we feel comfortable using, rolling it out for everyone. And those tests are still being developed. And so all the testing we do for antibodies is still somewhat on shaky ground. We're still developing the tests. We're still figuring out which tests are going to tell us which antibodies are better than others. So this is all being worked out in the background, and that's why sometimes this takes longer than people hope. But I think for the convalescent plasma story, Diana was our first, and this is really an opportunity for the other survivors to step up and do something that could potentially help this situation in our country and throughout the world. Regarding the question about what the plasma does, and so it's what we believe, or what the science would suggest, is that there are antibodies in plasma. So your immune system, when it learns to fight a virus, and this is sort of how a vaccine works as well. So when you get a vaccine, the vaccine is teaching your immune system how to fight the virus, and then your immune system makes antibodies against that virus that will protect you should you see that virus the next time. And so with convalescent plasma, the idea here being is that someone who's already cleared the virus has learned to fight the virus and has produced potentially life-saving antibodies. And so we can collect the plasma, which contains the antibodies, and then give it to others. And this is something that we currently can do because we have so many survivors out there that have these antibodies. But this is not going to be the ultimate solution to the problem because plasma is difficult to transport. And so we're already working with industry partners on the next step. And this is partly why they're building such a large national resource of plasma, is that you can pool all the plasma together, virally inactivate it, and then extract out the antibodies and create something called hyperimmune globulin. So these are purified antibodies that you can put in little vials and then theoretically ship them around the world very easily. It's currently being done that's one of the treatments for rabies, for example. If someone gets exposed to rabies, the treatment for it is hyperimmune globulin to rabies. And so that is the next step. And then ultimately we need a vaccine or something that's going to get us to fully be able to reopen society. But these measures can protect people for quite some time because antibodies circulate in your system for months. If there's a very big effect, if it's very protective, then we would know relatively quickly, because whenever you do a clinical trial, you have something called stopping rules and interim looks at the data. So we have planned to look at the data at periodic time points so that we could see whether there is a big difference between those who were randomized to the control or those who got the convalescent plasma. And there are ethical boards who sit there and statisticians who will sit there and review the data and decide whether the data is sufficient to stop the study. That's another reason why we want to do this to the extent possible as a multi-center trial with more institutions working together, because then we get to the numbers we need much more quickly and we can provide the results in maybe weeks to months, or to a month, as opposed to waiting 3 years like some trials can take. And again, it's really to bias those, a mother protects her baby with antibodies. So babies are born without the ability to make antibodies. And the antibodies the baby gets from their mother protects them for the first 3 or 4 months of life. And so it's sort of a similar concept. It's going to protect people for 2, 3 months, and then either we'll have to dose again or have other, hopefully in 2, 3 months, we're going to be in a different place and we'll have other options for treatment. And in plasma is where the antibodies are. And part of doing convalescent plasma is being able to test for antibodies. And so we have literally spent the last month developing tests for the antibodies. These are complicated tests. We're going live today with a new test that we're going to begin offering our healthcare workers here at Columbia. But again, these are still not perfect tests. So, there's still false positives and false negatives that require some interpretation. We're not there yet with a perfect test, but we think it's good enough. The test we have currently is good enough to begin rolling out to our communities. But these take time because we're not getting the test from manufacturing. We're building it in-house, which means that there are shortages, reagents, of reagents and things like that. And so our capacity is growing and we're rapidly ramping up, but it's going to take some time. And so that's where sort of my research focus has been on the antibody testing and the convalescent plasma. And regarding the antibodies, it gets even more complicated because currently we're testing for antibody titer, which tells you how much antibody is there. But there are other tests you can develop that will test how effective the antibodies are. And that's called a neutralization titer, which is really what we want to know. So there are antibodies that target specific parts of the virus that neutralize it. In order to do those tests, you need a facility where you can grow live virus to see if you can inhibit the virus using the antibodies. And those are tests that are currently under development at our institution and at other institutions. And those are really the tests we want to use on the convalescent plasma to see which ones might be more effective or not. But before we can even roll out those tests, we have to figure out how they work and be able to, in a sense, mass produce them so we can do it on a larger scale. So the question of dosing is an issue because we don't know. We think that 1 unit is enough, and 1 unit is about 200 to 250 milliliters. That's based on calculations about the antibody concentration in the plasma versus the size of an average adult. Now, some countries are approaching this a little differently, and instead of giving 1 unit, for example, in Italy, I know they're planning on giving it 1 unit every day for 3 days, for example. So there are different approaches in different places. But when Diana donated, she donated more than 1 unit. And so it's not a regular blood donation. They actually put you on a machine that spins down your blood. It gives you back your red cells and just takes off the plasma on top. And so from that process, you can get, for many people, 3 and sometimes even 4 doses from a single donation. And so one person could potentially provide 3 or 4 doses to help us, to help at least 3 or 4 different people. And then you could now donate every 7 days. And so one person could theoretically, over the course of a month, donate 10 to 12 units of plasma to help others.